We know the importance of lymphadenectomy as oncologists. We know that it's an important part of management of almost all the cancers. The end staging for a few cancers, for example, the oral cavity squamous cell cancer. This is for the breast cancer. This is for esophagus, stomach, and colorectal. If we observe that the number of lymph nodes, the amount of disease in the lymph nodes, the presence or absence of extranodal extension, to summarize, the amount of disease that has spread to the lymph nodes play a very major role in the end staging of these cancers. Very similarly, coming to the gynecological cancers, we have four. In vulva, if we observe, the number of lymph nodes that are involved, the amount of disease in the involved lymph nodes, the presence or absence of extranodal extension, basically the disease burden in the lymph nodes play a very major role in the end staging of vulva cancers. Deviating slightly from this, we have ovarian cancers, when in the end staging, in the presence of lymph nodal metastasis, the size of the disease, the lymph nodal metastasis is less than 1 centimeter or more than 1 centimeter. Just that is important. The number of involved lymph nodes do not play a major role. Deviating further from this, in cervix and endometrium, just the presence of lymph nodes is required for staging, is required for the end staging. If there are no lymph nodes, it's N0. If the lymph node metastasis is confined to the pelvis, it's N1. If it has gone to the para-aortic lymph nodes, it's N2. This is common for both cervix and endometrium. So we'll be discussing why this discrepancy, and we'll be discussing the role of lymphadenectomy in the four gynecological cancers in the same order: vulva, ovary, cervix, and endometrium. Role of lymphadenectomy in vulval cancer, there is absolutely no doubt or controversy. This is just like the management of a squamous cell cancer of penis. It has a definite therapeutic role. SLNB is acceptable if clinically node negative. If on examination and on imaging there are no involved inguinal or femoral lymph nodes, SLNB is an acceptable choice. But if the sentinel lymph nodes are metastatic, we need to do a completion groin node dissection, because as we know that the in vulval cancers, lymphadenectomy is extremely important for disease control, and it has a therapeutic role in that lymphadenectomy translates into cure, translates into an increased chance of survival. If we fail to achieve control in the lymph nodes, the disease will recur in the groin, just like cancer of penis. Once it recurs in the groin after a primary management, it is very difficult for control, because it usually almost always spreads to non-regional lymph nodes and with distant metastasis also. So achieving lymph node control is paramount in vulval cancer. Why do we do lymphadenectomy in ovarian cancer? So a 45-year-old female presents with vague abdominal symptoms. On evaluation, she has an adnexal mass that is suspicious. CA 125 is elevated. There are no other signs of disease anywhere else in the abdomen or the thorax or in the pelvis. So it's an ovary contained disease. So our plan will be a staging laparotomy, do an adnexectomy and a frozen section. And if the frozen section is a cancer, what do? We do a pelvic and a para-aortic lymph node assessment. Why do we do this? So it's very clear. In early stage cancers, we know that ovarian cancers predominantly spread to the peritoneal surface. It's a peritoneal surface malignancy beyond a particular stage. So peritoneal surface deposits will make it stage 3B or 3C, 3B and above. And lymph nodal metastasis will make it stage 3A. So in cancers that are less than 3B, that is in disease that is confined to the ovaries, fallopian tubes, and uterus, we need to do a lymph nodal assessment to accurately stage the disease, so that the appropriate adjuvant therapy, systemic therapy, can be initiated. And it also has some therapeutic role, but we now have very good evidence that in the presence of peritoneal disease, gross peritoneal disease, in 3B and 3C, when we are doing a cytoreductive surgery, lymphadenectomy does not have a significant role, does not have a therapeutic role. This was proved beyond doubt in this trial, the Lion trial, very popularly known as the Lion trial. So, in ovary, it's very simple. In early stage disease, in ovary confined disease, in uterus confined disease, we need to do a staging lymphadenectomy of the pelvis, and we also have to do a para-aortic lymph nodal assessment. But in stages upwards of 3B, when there is gross peritoneal disease, the role of lymphadenectomy is absent. It does not add any survival benefit in addition to doing a cytoreductive surgery. By this, we mean that enlarged lymph nodes have to be debulked. So, we are basically debulking wherever the disease is. We are doing a cytoreductive surgery. Wherever the disease is, we are removing that. So, very similarly, disease in the lymph nodes can be removed. We don't have to do a formal lymphadenectomy in the full template. So, that is the meaning of this Lion trial. Now, these two are very straightforward. And this is also relatively straightforward. We know very well that in cervical cancer, the surgery starts with a lymph node assessment. So, if cervical cancers have already metastatic lymph nodes on imaging, we directly subject the patients for chemoradiation. The removal of bulky nodes and then sending the patient for chemoradiation has no role. This was proved in a uterus 11 study where there was no difference in DFS. There is no use in doing that. If metastatic lymph nodes are found on imaging, we can directly send the patients for chemoradiation. If there are no metastatic lymph nodes on imaging, and if the patients are planned for surgery, the first step of the surgery is lymph node assessment. And if there are any involved lymph nodes detected by frozen section or imprint cytology, any further surgery should be abandoned, should be discouraged. No further PLND. So we have found metastatic lymph nodes on pelvic lymph node sampling. So that does not mean we have to go all in with all guns blazing, remove all pelvic lymph nodes. There is absolutely no benefit in doing that. No further PLND, and the planned surgery of radical hysterectomy should be abandoned, and the patient should be referred for definitive CTRT. Because in the final histopathology after a radical hysterectomy with a bilateral pelvic lymph node dissection, if there are positive pelvic lymph nodes, it automatically becomes an indication for adjuvant chemoradiation. So, subjecting the patient to a radical hysterectomy, bilateral pelvic lymph node dissection, followed by the same adjuvant chemoradiation, adds significantly to the morbidity. But does it cause any benefit? So, why should we abandon the radical hysterectomy? Many residents have this doubt. Why not? Why don't we complete the radical hysterectomy and then give her the benefit of adjuvant chemoradiation? Wouldn't that offer a better oncological control? We have evidence to prove otherwise. We have this trial called the Aberex trial, which has shown that in the presence of intraoperatively detected pelvic lymph node metastasis, abandoning the radical hysterectomy versus completing the radical hysterectomy, there is no difference in either recurrence free survival or overall survival. But by completing the radical hysterectomy, we may be injuring the autonomic nerves of the pelvis, causing bladder disturbances and bowel disturbances. And by doing a pelvic lymph node dissection, we are increasing her chance of lymphedema, because combining both a pelvic lymph node dissection and a pelvic EBRT significantly increases lymphedema chances compared to EBRT alone. We will be increasing her chance of retroperitoneal fibrosis, and all the long-term sequelae of chemoradiation are going to be more morbid for the patient. So that is why it is very clear: intraoperative lymph node assessment, if positive, the surgery stops there in cervix. Now, the last and the most interesting part, The role of lymphadenectomy in endometrial cancer. This is my favorite area. So if you read all the textbooks, all the guidelines, classical sentence, two randomized controlled trials have shown that pelvic lymphadenectomy does not improve survival. You will find this in all the textbooks on endometrial cancer, all the guidelines on endometrial cancer. The two randomized controlled trials, which they are all talking about, are these: the MRC Aztec and the other trial. Now, after the publication of these two trials, there have been a series of publications criticizing these two trials. So, there are so many flaws in these two trials that did not show a survival benefit of a pelvic lymphadenectomy in endometrial cancer. First, there was no standardization of the extent of lymphadenectomy. There was no standardization of patient selection, and anyone could do the procedure. There was no specific subset of surgeons performing the procedure. And in one of those two RCTs, so the first randomization was lymphadenectomy versus no lymphadenectomy. So after that initial randomization, so there had to be some logic in the adjuvant, right? So some patients with pathologically involved nodes did not receive any adjuvant. Some patients in the arm which did not even undergo lymphadenectomy underwent adjuvant treatment. This was so random. There was no standardization of the adjuvant based on the lymphadenectomy HPR. So, all these are so many inherent flaws in these two trials which failed to show the therapeutic benefit of lymphadenectomy in endometrial cancer. So the guidelines say if pelvic lymph nodes are found intraoperatively, further pelvic lymphadenectomy is to be avoided. However, debulking of enlarged lymph nodes can be considered. So another thing, so if intraoperatively lymph nodes are identified, the proper uh, uh, guideline as to what needs to be done next is not yet completely defined. It's awaiting the results of an ongoing trial. It's a very beautiful trial called ECLAT, which will definitely answer the question whether pelvic lymphadenectomy is therapeutic for early stage endometrial cancers. But till then, in summary, for vulval cancers, lymphadenectomy is definitely therapeutic. It's not PLND for vulva, it's groin node dissection for vulva. We need to achieve control of disease in the lymph nodes, and that translates into a chance of cure for the patient. In early stage ovarian cancers, where there are no peritoneal deposits, lymphadenectomy is to be done for staging purpose, for accurate assessment of the stage, so that the adjuvant systemic therapy decisions can be made, and it has some therapeutic benefit. It offers some progression-free survival benefit, disease-free survival benefit. In advanced stage ovarian cancer, when there is gross peritoneal disease, there is no role of a formal lymphadenectomy, but removal of enlarged nodes can be done as a part of the cytoreductive surgery that we are doing. It is just as a part of the removal of disease, cytoreduction, debulking. So we have to debulk the disease in the lymph nodes also. There is no need to do a formal template lymphadenectomy. In cervical cancer, lymphadenectomy is purely done for staging. There is no role for debulking. We know that debulking of lymph nodes do not offer any DFS benefit or OS benefit, and completion of the surgery by PLND or radical hysterectomy offers no benefit at all. So the surgery stops there. If intraoperatively pelvic lymph nodes are found to be metastatic, the surgery stops there and the patients are referred for adjuvant chemoradiation. Otherwise, we would actually be doing the patients harm by increasing their morbidity by doing a complete surgery. In endometrial cancer, again, it is for staging only until 2031 when the results of ECLAT are published. But debulking is beneficial because of the above said reasons, because the two randomized control trials which failed to show the therapeutic benefit of lymphadenectomy had so many inherent flaws. So, debulking is to be considered if intraoperatively enlarged pelvic lymph nodes are found from endometrial cancer. Finally, our last summary, we now saw that from endometrium and cervix, a paraortic lymph node metastasis would make it 3C2, whereas in ovary, it is 3A1. Just a very easy way to remember this. There's no need to by heart or mark this. Ovary, like the testis, is a gonad which derives its blood supply from the gonadal artery, which is a direct blood supply from the aorta, direct branch of aorta. So that is why the landing zone for the gonads, for the testis and ovary, are directly in the paraortic lymph nodal chain because the lymphatic drainage usually parallels that of the blood supply, whereas from the ovary and from the cervix, they go to the iliacs and then the common iliacs and then they ascend up to the paraortic. So that is why a paraortic lymph node from an endometrial cancer or a cervical cancer will be stage 3C2, whereas uh, a paraortic lymph node from an ovarian cancer will be stage 3A1.